This webinar is the first webinar series from this group. So introduce our guest speaker today. Today we have Professor Prof from Netherlands. He is a radiobiologist. And also for the panelists, we have Judi van Diessen. She is a radiation oncology from Antoni van Leuwenhoek, Amsterdam. And also we have two radiation oncologists also from the panelists. One is Dr. Ericko Ekaputra from Sardjito General Hospital, Jogjakarta. I would like to thank you for Ericko for introduce this link for us. And also we have Dr. Dion Firli from the Dr. Kariadi Hospital, Semarang, Central Java. So first of all, of course, I want to thank you for Professor Kops for giving time for sharing the knowledge and perspective about radiobiology in fractionation in head and neck and CNS malignancy. I do hope this webinar can initiate further collaboration in the future, and also I also want to thank you for Ericko, as I mentioned before. Today's webinar, our topic is fractionation in head and neck and CNS malignancy, radiobiology perspective. And we are really excited to share what we know with you. We will be discussing about the basic concept and clinical applications, and we hope that this will give us the practical tips that we can use in our practice. We have also the question throughout the webinar, so please feel free to type them into the chat box, and I will ask to the Professor Pops about the questions. So before we start these webinars, we will hear some welcome address from our President of IROS, Dr. Ben. Dr. Ben, please, time is yours.
Thank you very much, Dr. Henry. Yeah, so welcome everyone, and thank you for joining another one of our IROS CME webinar, this time from the Head and Neck and Central Nervous System Group. As Dr. Henry Kodrat mentioned earlier, this has been made possible through a collaboration between Sardjito Hospital and several institutions in the Netherlands. Thank you very much, Dr. Ericko and Dr. Judi van Diessen for initiating the initiative. Now, welcome, Professor Kops. Thank you very much for agreeing to share your expertise with us in this occasion. To everyone here, I hope that our webinar this afternoon will be useful and relevant both for our daily practice for the practicing radiation oncologist, as well as for the preparation towards becoming a practicing oncologist for our residents here in the audience. So Professor Kops, just a bit of background. Our audience this afternoon will be a mix between residents and radiation oncologists. So I think what you mentioned earlier with starting from the basics will be a good start and a good approach for our program today. So without further ado, I will just return to Dr. Henry Kodrat to initiate the session. Thank you very much.
Thank you so much, Ben, for the introductions and welcome remarks. So before I hand over to Professor Kops, I will introduce Professor Kops. Professor Kops is a professor of radiobiology from UMCG Groningen, University Medical Centrum Groningen from the Netherlands. So without further ado, let's start this webinar sessions. Professor Kops.
Okay. Thank you very much for introducing me. And yeah, so what I try to do in this time that I have today is more create understanding of the background where you have to think of if you would do, for instance, radiation. I plan to focus on the brain, on the head and neck mostly, because I think it's not enough time to do everything. And at the end, the basic mechanism behind it are similar, which you have to keep in mind, right? So it's also mostly valid for a lot of other sites as well. So I will share my screen now, if I can find it. Oh, there's something not working. I'm somehow not allowed to share the screen, so I have to. Okay. I have to
Okay, we will wait for the Professor Kops for joining us again.
Yeah, now I see something. Yeah, do you see my screen now?
Yes, we can see your screen.
Okay, sorry for the delay. Yes, as I said, it will be kind of a radiobiology perspective, starting from the start. So in principle, why we do research in radiobiology and of course also in radiation oncology is to increase as much as possible the therapeutic window. So in principle, the response of a tumor follows this S-curve with a steep incline with radiation dose and the effect, but also the normal tissue that is co-irradiated follows the same kind of response, and this is also an S-curve, which is a relation to the dose and the effect. So your therapeutic window is the difference between especially my lab, but also in other labs, is that we, for instance, try to reduce the effect on a normal tissue, thereby increasing the therapeutic window that for a certain effect of your tumor, say 80% tumor control, you will have a limited level of normal tissue damage. However, if this involves also that your tumor control is affected by the treatment that you give to the normal tissue, or the other way around, you see that the change has no effect because the difference between the tumor and normal tissue is actually disappearing. So in this presentation, I will discuss for tumor and normal tissue cell survival, tumor response to radiation, factors that influence tumor control, and the normal tissue, and eventually go to stem cells and radiation. And at the end, this point to how all these things applicable in a set of radiation. So mostly what I will be talking about is also described in this clinical radiobiology book. And I teach also in the Astro course of the Astro in Europe, where a lot of these slides are also coming from. So first, the cellular effects of radiation. So in principle, the basic effect of radiotherapy is only that you excite an electron from a molecule, and this electron can then induce DNA damage. And 30% due to a direct effect of radiation on the DNA. But 70% of the effect of radiation is actually due to the hydrolysis of water. And you can see here that in the water molecule, the electron is excited, then you get a chemical reaction, and this inflicts the damage to the DNA. And this is 70% of the effect. And this is important to know, because I will get back to that later why it's is important. So this is how radiation affects this effect, and after DNA damage, you can see that something will happen to the cells that that they will change the way they divide. You can see here a movie of a cell where the DNA is colored in green, and you can see when the DNA is copied, it is nicely aligned, and then the cells separate, and you have two exactly the same copies of your DNA. However, after radiation, what you will see is that radiation damages the DNA, and an irradiated cell, as you can hear with the green of the DNA, is able to duplicate its DNA. However, when it tries to divide, you will see it's impossible to find the right copies of the DNA together. And what happens is that either the cell stops here, or it will divide proper DNA that is connected, and you can see it divides in two cells that are completely different in the amount of DNA. And this causes cell deaths in these cells, and this is the way how radiation actually kills, for instance, your tumor cells, but not only your tumor cells, also your normal tissue cells. So the radiation can inflict a lot of different types of DNA damage, but also UV and all kind of other stuff that is targeting your DNA. But the major effect that radiation causes is double-strand break. So you can see it inflicts single-strand breaks, abelic sites, DNA protein cross-links to the DNA. But these can all repaired. These can all be repaired by DNA repair, where you just copy the other side of DNA. The only part where that's not possible is when you have a double-strand break. And these double-strand breaks are responsible for the effect that I showed you in the previous slide, where you have like a mixed up number of DNA copies in your cell. So indeed, it is shown that the double-strand breaks are the most relevant lesions for the biological effect of ionizing radiation. And that one effect actually induces like 63% of cell death, because sometimes you have zero events, and sometimes you have too little events, and that doesn't overkill your cell, right? So for, say, a gray, about 1,000 base damages and about 1,000 single-strand breaks, but these can all easily be repaired by copying the other strand, for instance, by base excision repair. But the double-strand breaks are more difficult to repair, and these are, you still can repair them, and they are in general repaired by non-homologous end joining on homologous recombination. And this is important to know, because that's different between the different types of cells. So the repair of the double-strand breaks are done either by homologous recombination, where the copy of the daughter DNA is actually lined up with the DNA of the other copy, where you have the double-strand breaks. And this can actually only happen in the homologous recombination at a time in the S phase, where your DNA is duplicated, and you have to have an extra copy that you can insert into the place where you have your double-strand break. So here you can see that a lot of proteins are involved in that. It's not so important to know exactly what these proteins are, but you can see that they will be attracted, and then what happens is that the proper DNA chromosome is actually copying its DNA into the one that is the daughter cell that is aligned next to it. And in this way, you can actually maintain your DNA in a proper way and without getting any mutation. So this is actually why they call it homologous repair, because it's like the proper repair without any scars left behind in your DNA. What also happens a lot is non-homologous end joining, and this is a different DNA repair pathway, where the double-strand break induced by irradiation is actually just kind of glued together. Some of the recognizing proteins are the same, but a lot of other proteins are different, like Q80 and Q70. And what happens here is that the DNA is just glued together through DNA PK, And at the end, you have a chromosome, which is kind of intact, but with this DNA repair pathway, you actually create mutants. So this pathway is mostly used in non-dividing cells. So if like a terminally differentiated cell that doesn't divide anymore, you can see that this is happening. And although you get mutations, as long as the cell doesn't divide itself, it actually maintains the chromosomal integrity, and that means that the cells can still actually function. So this is important to know how this works, because this has an effect, of course, on your on the effect of how you treat your radiotherapy. So to measure how radiation affects cells, have assays that use cell lines, for instance. You can grow from tumor cell lines and from some normal tissues, and you can study these the radiation effects by irradiating cells that you plate on a cell like this. So, for instance, if you plate 100 cells here and you don't irradiate them, you will see how many colonies are formed, and you can stain them blue and count them, and then you know how many cells are actually surviving the radiation or not. And you can see that indeed with increasing radiation doses, you get less cells that survive and that can form a colony, because that's important. If they just survive, it's not sufficient. We have to show that they lose clonogenicity. And this you can see here, right? So after radiation, you have DNA damage. The DNA damage either kills immediately the cells, or the cells are going into mitosis. They can sometimes do this a couple of times, but then still die. And that is what we call late cell death. And this can be due to all kinds of ways, apoptosis, senescence, autophagy, and necrosis, or mitotic catastrophe, of course. But the cells that actually are surviving and make a colony of more than 50 cells, for instance, are considered that they are clonogenic surviving. And this is important because not all cells die immediately. They sometimes take a while to die after radiation. With this assay, actually, a lot of biology has been explained in the last 50 years. And the idea is what you do if you use the assay and how many cells afterwards are able to form a new colony. And you can see here how this works. So this is a surviving fraction, and this is the radiation dose. So if you then increase the radiation dose, you will see your surviving fraction of cells is reduced quite rapidly. And then if you construct a dose response curve of this, you will get this. This is this F curve. However, this is very informative, especially at higher doses, because you cannot clearly see the difference. So what people did at that time was, okay, let's make the curve in a logarithmic scale, right? And then you see a very nice curve that you might be familiar with, where you see the dose response curve in this way. And this curve is actually very important, has been very important for the development of all kinds of models that kind of predict the response of your patient potentially to radiation, like this one. You can also see that these curves are quite different between different cell types. So this is a curve of cells that survive after radiation, where you see a normal dose response curve, where all the cells are behaving normal, but also a dose response curve of patients' material that from patients that suffer from ataxia telangiectasia. The ataxia telangiectasia is a mutation in a DNA repair gene. And if you have that, you have also you're very radiosensitive. And you can see this in this curve, that these curves are much steeper than the curve of the normal cells. And that's because they have a reduced level of DNA repair. And this DNA repair is actually making the shape of this dose response curve. So that's important to know. And the steepness of the shape has to do something with the ability to repair your DNA. So you can very nicely see here in this slide that this DNA repair is actually occurring while you are radiating. So here again, you have the surviving fraction. So there's the number of cells that are surviving and the dose, and or the interval between two fractions actually. So what they did here, they radiate first with 4-gray. And if you radiate these cells with 4-gray, you can see you have about, say, 3% of your cells that are surviving. However, if you split the dose in two fractions, then you can see actually that the second dose is actually less affected than the combined dose of 2+2. So 2+2 in radiation biology is not 4. It is a different value depending on the interval between the doses. And you can see that the first dose is repaired a little bit when you add the second dose. And you can see that the survival is bigger. And if you give another, if you give the two doses more time apart, you can see that the effect is getting smaller and smaller, and eventually repair actually that happens from the first dose of 2 gray. So this also shows you that it takes like about 8 to 12 hours in this cell line that the repair of the DNA is complete and you don't see an extra effect anymore, indicating that you need at least like 8 hours in between fractions to make sure that the previous fraction has been optimally repaired. So this experiment actually showed that there is a potential to spare tissue if you fractionate the doses, right? So this is what you do in a clinic. You give fractions of doses instead of one big dose. And with these fractions, you can see if you use the, say, 2 gray, that you may make optimal use of the repair component of the DNA repair of the survival curve. And I'll also show you a little bit later how that works. So here you can see that if you fractionate the dose, you can give actually a lot more dose than if you give the dose in one time because you make use of the DNA repair of the cells. So, and the reason why you do this in the clinic is because the tumor and the normal tissue have a different response to the radiation, and you can see here that often the tumors have a more shallow dose response normal tissue, and this is due to the fact that the normal tissue is often more able, especially for the later packs, more able to repair their DNA properly, which makes the curve more bendy. And you can see it here that the difference between the single dose and the fractionated dose is larger in the normal tissue compared to the tumor. So by fractionating your dose in radiotherapy, you actually separate the tumor from the normal tissue, even if you would irradiate with the same dose. And this is depicted here. So this effect you can actually use to calculate or recalculate your treatment, as you can use the characteristic of these curves for looking at how your effect of your radiation will be. And you can see that in this curve. Again, you see the surviving fraction, and you see a dose response curve of a cell line. And this dose response curve consists of 2 components. The first component is what we call the linear part. And the second component is what we call a quadratic component. So in my view, the idea is that if you are in the linear compartment of your dose response curve, this part, you can still repair your DNA. Are so big that you cannot really repair it anymore. Then you get into the quadratic component and you can see the line becomes very steep and a straight line. So we can use these characteristics, which are different between all cell types, as I just showed, by making a calculation where the linear component is the alpha component and the dose component, and the quadratic component is the beta component, with the quadratic formula of the dose, right? So then you can calculate an alpha beta value of all the different types of cell lines, but also tissues. And you can see the alpha beta is the part where the linear and the quadratic component are equal. So this is what they call the alpha beta. And you can establish alpha beta from cell lines and from all kinds of tissues. But in general, to remind you, is that high alpha beta is often when the curve is shallow, and a low, or when the curve is kind of straight, and the low alpha beta is when the curve is more bendy. And the low alpha beta is often for late responding tissues, and these have a nicer curve because they have actually a better DNA repair component in it. And for instance, tumor are very early responding tissues. So, and this is then the formula where you can actually calculate your effect if you. However, these are not very handy to use in the clinic, right? So they formulated a different way of calculating your effect, and this is what we called the biological equivalent doses. So you have a lot of knowledge on the dose that you deliver, and if you have a fractionated dose, you know exactly what the patient should be able to tolerate, and you can calculate that as a biological effective dose, where the total dose is the BAD is the total dose times 1 plus the dose per fraction divided by alpha beta of the tissue or the tumor. And then you get a biological effective dose. But this is also not very handy to use. So they can recalculate it to an 2-grade dose per fraction equivalent component. And this is the EQD2 dose. And then you get this formula. So you can calculate with that, and you can compare actually different types of fractionation schedules to see if your dose is like okay for your tumor or okay for your normal tissue. And you can see if you change your schedule, you can see if you can use that to optimize your treatment or to be careful whether or not you over irradiate your normal tissue. And this is very important, and we'll get back to that later in the calculation of how you can use re-irradiation, for instance. Another effect that is very is hypoxia. We know that tumors can be hypoxic, and you can see a slide here of a tumor where you see oxic areas, and so this is the blue stainings are blood vessels here, and you can see that you cannot see anything in this staining around the blood vessels. That means that the area here of this tumor is nicely oxygenated, and you cannot see it because the other stainings, the green and red staining, are stainings that show hypoxic areas in your tumor. So you can see that from a certain distance of your blood vessels, you get a hypoxic area in your tumor, which is stained green and red here. And then if it's further away, you can see, you cannot see any staining anymore, but an N of necrosis. That means that the cells here are already dead due to lack of oxygen. And this is very important that you know that tumors may be hypoxic because the radiation is actually highly affected by oxygen. So I showed you already the radical forming of water that is inducing the effect of radiation. So you have a direct effect of radiation directly to the DNA, but also through water molecules, since you're 70% of water molecules. If you put oxygen next to that, actually the damage is fixed because of the oxygen, and you get these radicals. And this is actually more toxic than without oxygen. So that means that the areas in your tumor that are hypoxic might be resistant to oxygenize your tumors. So this is a very schematic drawing, so this is not real life, of course. So, but in principle, what you could have is that you have a tumor which has an hypoxic area in the center where there may be not that many blood vessels. And if you radiate it, the sensitive cells, which are the hypoxic cells, may die. But the hypoxic cells that are radioresistant may survive. So what you will have after a fraction says that you killed the oxygenated cells, but the hypoxic cells are remaining. Then if you wait a while, the blood vessels that are reopening again or reformed again may make the tumor that you have irradiated oxic again for some part, and then you radiate again, you kill the oxic cells, and you are still remaining with the hypoxic cells. So if you do this many, many fractions, eventually you kill the tumor. So this is also something to take into account if you use different radiation fraction, that you might affect also the hypoxic fraction of your tumor. So now I want to go to how in the radiobiology actually we determine the effects of radiation on tumors or on normal tissue. And first I will go over the tumors a little bit. And then you hopefully you'll learn what you can do with that at the end for retreatments. So this is like the whole age of cancer. which you probably all know, is that have to have a lot of characteristics to make it into a tumor, and these are all these characteristics you have. But it's very important that you realize that actually it disturbed tissue homeostasis also drives the functional capacities of acquired tumor genesis, right? So what you actually need to create a tumor is a catalog of 6 cell cancer genotypes that are essential to eventually create a tumor, right? So 6 of these parameters mentioned here have to be changed to make a tumor malignant. And all of these are affected, can also be affected by radiation. So you can measure many endpoints, right? And this is between radiation oncologists and other types of cancer treaters, kind of sometimes a bit of a different approach, right? So in principle, if you treat a tumor, you can get tumor regression. There's no specific endpoint for that, just a measure of the tumor size. And if it's not fully dead, actually it's not so beneficial, right? Because it's the tumor will regrow again. So this regrowth of the tumor you can also measure, and that is more quantitative, because you kind of study first the decay of the tumor and then the time it takes to regrow, and this tells you something about the capability of the tumor to regrow. Of course, is local tumor control, and this is of course the aim of radiotherapy, and and we can do a lot of improvement to make sure that this is translated in prolonged survival, right? Because a tumor growth delay may be beneficial for some time, but it's not really curing the patient at the end. But to get a local tumor control, you actually have to kill all the clonogenic cells that I mentioned, right? So these all have to be inactivated, and that is actually not so easy. So you can see here how that would look like. So on the left, you have the tumor surviving cells, so the clonogens per tumor, and on the bottom, the radiation dose. So if you give a certain radiation dose, you might not kill all the cells, and you say you start with 10 to the 9 cells, you actually need to kill the very last cell to get the tumor response. So if you do not give enough dose, you get a partial response, and the tumor will regrow again. And you have to give actually a lot more dose than the partial the response to get a really local tumor control up to a level that you actually do not see any surviving tumor cells anymore. So this is important to realize, that all the clonogenic cells have to disappear. So next to the assays I already showed you, where you can test the clonogenicity of cell lines, for instance, and that curve that I showed you, for which you can calculate alpha, betas, etc. You can also do similar assays directly from the tumor. So you can, for instance, have a tumor that grows into a mouse that you transplanted in there, or that you make it grow there. Then you can take out the tumor, make a cell suspension, put this cell suspension on a culture disc, and then grow colonies from this cell suspension and irradiate those to see what the effect of radiation is. So this is what we call an ex vivo assay, and it's a little bit better than looking at just cell lines, right? Cell lines are often very homogeneous and are prone to grow a lot because they have been in culture for many years, and they might not resemble anymore the original tumor. So this is a little bit better to do that. So that is what we call an ex vivo assay. However, there are nowadays also better assays that actually show you better how to quantify the response of a tumor. So you can also culture these tumors as organoids. So an organoid is a tissue resembling a structure that is actually derived from stem cells. So stem cells can make all the different types of cells of a normal tissue and a tumor, and you can nicely study those to see the radiation response. So the tumor, you can take a biopsy from a tumor, for instance, reduce it to single cells, and then grow them in a 3D matrix. Allow the tumor stem cells to grow an organoid or a tumoroid, which resembles actually the tumor. And they also show cells that are differentiated in all the subtypes of the tumor cells. The only disadvantage is compared to a real tumor is that they lack environmental factors and vascularization. So I'll show you a little bit the idea behind this. So in a normal tissue, we have stem cells, and a stem cell is defined by the fact that it can self-renew, so make itself, but also proliferate all the different cell types of this specific tumor or tissue. Then you have a tissue stem cell. However, for tumors, you have the same, and we also have defined the cancer stem cell, which can self-renew, but also repopulates the tumor after radiation or after transplantation, and then differentiate in all the different cell types of a tumor. Although they are not as differentiated as in normal tissue, you do find different cell types in the tumor, and the tumor can be very heterogeneous. So the characteristic of these cancer stem cells are that they can self-renew, that they are capable to develop multiple lineages. They are chemo and radiation resistant, so they can repopulate the cancer after a treatment, and they can form a sphere or organoids in culture. And they can regenerate then the tumor in immune deficient mice. So I will show you a little bit how. Yeah, so this is mine. Yeah. Okay. In principle, if you have a tumor with different types of cells and you would irradiate that, you do sometimes see a tumor response. But if the tumor response is not complete, it's most likely that the surviving cells have stem cell characteristics. And they are radiation resistant and then regrow the tumor. So just the tumor grow response is not sufficient. You really have to kill all the tissue stem cells to cure the tumor. So these cancer stem cells have characteristics that you can see. For instance, they have markers on the cell type that are, for instance, typical CD44 and CD24. So if you take all the cells out of your tumor, you separate them by FACS, every dot is a cell, and you collect the cells that are potentially stem cells, and you seed them into a plate, you can see that the cell type here on the left, which is high in CD44 and low in CD24, is growing most of the colonies, even if you seed for the same number of cells, indicating that these are potentially stem cells, and they can grow these nice spheroid structures in your 3D culture. And you can see that after radiation with a fixed dose here, also these cells with these markers are actually surviving cell types, indicating that these cells are more radio resistant. So also, if you transplant these cells into a mouse on the skin, you can see that the stem cells are actually more aggressive and grow a tumor much faster than the ones with less stem cell characteristic or the complete population. And you can see those here. And you can see a relation between the time to response and the level of the stem cell markers they express. Interestingly, when you look in a tumor, you can see that these stem cells always reside at a niche which is hypoxic. And the idea for that is that in the hypoxic area, cells become de-differentiated and may become cancer stem cells due to the lack of nutrients and oxygen. In this way, they kind of consume all their content and become de-differentiated into stem cells and also become resistant to radiation, indicating again the importance of the microenvironment of these cells. So the interesting thing now is that you can actually grow these organoids from all the patients that you have. So here you can see organoids that are grown from tumors, and you can see how they look like. So these are different tumors. From metastasis, you can also grow organoids from those. And they resemble, if you look at the cell types, they resemble very much the different cell types that you find in the actual tumor. As you can see, they are kind of similar. So what you can do then, you can take a biopsy from the patient, grow these in culture and radiate them and look at the surviving fraction. And you can see that how they respond to chemo, for instance, and to chemo plus radiation. So we nowadays use this assay to see if we can predict the radiation response of a specific patient to chemotherapy and to radiation, for instance. And that is actually quite nice, because until now we actually use a generalized model for everybody. So these type of in vivo models, you can transplant these organoids into a mouse, and then you regrow a tumor. So you can also study the effect of other components of the environment. So here, for instance, they did in vivo transplanted tumors in two different ways. And this is what they call the tumor bed effect. So if you radiate first the place where you are putting your tumor, you actually damage the microenvironment and what they call the tumor bed. And this contains, of course, mostly the vasculature. And you can see actually if you transplant a tumor in there that grows, it's actually more sensitive to radiation, not irradiate the tumor bed, indicating that the vasculature where the tumor is actually is very important for the response of the tumor as well. Okay, then you can actually calculate nicely from tumors that you have irradiated by looking after radiation in the tumor, where you see regrowth after some time, and you can calculate these dots here. And with these dots, you can see that with increasing dose, you see less and less clonogens that are able to regrow. You can create nicely these tumor response curves, which you can use, for instance, to calculate alpha betas again. But again, you have to kill all the cells, all the cancer cells, before you really have a tumor response. So in principle, it looks like this. You have non-stem cells, cancer stem cells, and no tumor cells left. If you, this is a normal tumor, if you radiate to a low dose level, you will see you still may kill quite a bit of non-stem cells, but you still have all the stem cells remaining. With a little bit higher dose, you already kill some stem cells. And even if you kill only the stem cells at the end, you will have a total response. And here, if you kill all the stem cells, you have a total response. And then you get this kind of S-curve, which you can measure again with this transplantation of these tumors. So if you would combine this, you could, for instance, try to kill specifically your stem cells. So if you add a drug to your tumor that seems to synthesize your tumor, it might without drug and with drug, it might kill only the non-stem cells, where you see a dose, response of your tumor, which looks like you do a good job. However, since the stem cells are not affected, the tumor will regrow, and at the end, the tumor control probability is not bigger by your treatment. However, if you use a drug that would also affect your stem cells, then you might kill only the stem cells and not even all your non-stem cells, but this will induce a dose response curve shifted to the left, right? Because you kill the stem cells and you actually cure the tumor with a lower dose of radiation. And of course, this is what we try to do to optimize cancer treatment nowadays. So to wrap up this the part of the normal tissue or the tumor, we can make all kind of survival curves which are characteristic for specific tumors, for which you may calculate an alpha beta component. But the tumor is also influenced by, of course, the tumor cell radiosensitivity by itself, which is depicted by this curve, but also by hypoxia, the level of proliferation, vascular sensitivity, but also by the tumor volume. And to wrap that completely up in the summary, stromal interaction, microenvironments, tumor volume, and cell proliferation. Taking into mind always that it's a certain population that induces the repopulations. So tumor models can be used to explore different treatment regimes and to look at different important biological pathways like the ones that influence your stem cells. You can look at volume responses, measure time to regrowth, and calculate from those doubling times of your tumor when comparing tumors. And of course, tumor cure is the gold standard. And this is not possible with the drug alone because it will never kill all the tumors, so you need the radiation with it. And many animals and long-term survival need to be studied to see if it really a drug is improving your tumor control. So now I will go over to the normal tissue, because of course you also want to have a therapeutic ratio. So in the normal tissue, we distinguish two types of responses, the early response and the late response. And so the early response is in rapid proliferating tissues like bone marrow, mucosas, and dermis and skin. And radio-responding tissues are mostly with tissues that have a very slow cell turnover, like lung, central nervous system, and kidney. So the early effects are, do have an effect on quality of life. Can be dose limiting, for instance, for oral mucosas, and they need often supportive care, and this is cost money, right? And they can be enhanced by chemotherapy, smoking, alcohol, and spicy food, because that induces extra proliferation of these cells. So the pathogenesis of normal tissue side effects are shown here, but early effects that is also always in tissue, like I said, with high proliferation. They are mainly due to cell loss. They are often accompanied by inflammation, and the recovery of these are often complete if you don't overdose too much, because the surviving stem and progenitor cells will divide and migrate from outside the radiation field to repair the tissue, and at the end, so the early effects may be temporarily and not make a problem. So the biggest problem for radiation actually are late effects. So late effects occur in all tissues. The effects are next to the effect on parenchyma, also due to the effect, for instance, on connective tissues and blood vessels. The immune response plays a very important role, and it's irreversible, so you do not get recovery if you with a certain dose, and it increases in severity and time, and the risk actually remains the entire. Again, like in a tumor. And in normal tissue, you have a balance between cell production and cell loss. So when a cell is dying that has a certain age, then the stem cells need to produce new cells. So the cell loss is actually determining the cell division speed of your stem cells. So when a cell has a short lifespan, like in your gut, it will be replaced like after 3 days to a week or so, then the stem cells need to already divide very quickly. In tissues where you hardly have any cell loss normally, because the cells live very long, like in your brain, but also in your kidney, for instance, the stem cells will only start to divide after a very long period, and your tissue might only respond after years after radiation. So the cell loss is then after radiation. It could be some apoptosis that you use and functional reduction of the cells, but mostly the functional mature cells with a limited lifespan actually determine your response. And then tissue stem cells and progenitor cells need to produce these cells. And actually, these are the ones affected by radiation, because these are dividing. And if the DNA is messed up, you can, well, like I showed in the beginning, they cannot do that. You can see very nicely in this slide, actually, that the number of proliferating cells in your tissue determines the time to response after radiation. And these are the early response tissues where you have a very high proliferation in your tissue, and these are often also have a beta, and are kind of more radiosensitive and as sensitive as the response to tumors. However, the late responding tissues, they have a low alpha beta, have a low cell turnover, and you can see here it takes also longer for them to respond after radiation, depending on the dose. So this is dose independent, because they will always respond in this time, and this is dose dependent. So if you give a lower dose, the damage may just occur at a later time point. And this is very important to realize, because when you see your patients at a certain time after radiation, it might be that they do not show yet a late response because you are too early, but they might still develop that late response in a later time. And this is due to the turnover of the tissue, right? So if you would irradiate a tissue, the number of cells that can repopulate your normal tissue is declining depending on the dose, and the steepness of this line is dependent on the cell division and the cell turnover time. So this is the time to respond after radiation. If you give a certain dose with a clinical effect, then you can see here that you already inflict damage before you see the clinical effect. And that if you stop treatment before you reach that clinical effect, you still have damage, and it takes some time for the cells to repopulate to come actually back to the normal state. So this is important to realize also radiation. If you give a higher dose, you will do see a clinical effect. Will take a certain time, and then you can see after a certain time, again, it seems that the clinical effect is gone, but the tissue is still not completely repaired. So this is what we call the latent time to respond, and this is the time for clinical healing. And this is then the time to completely restore your tissue. So that depends on the radiation dose you give and the steepness of this curve. And you can see here that if you do give a bigger dose, the latent time is will be the same for early responding tissues. It will take only longer to recover again and longer for complete restoration. So for late responding tissues, these curves are very, very shallow and you get a different response. So to understand a little bit more about the stem cells and how important they are, I will explain a little bit here. So a stem cell can divide in itself and self-renew itself, so make itself, and a progenitor cell that can potentially divide in all the different cell types of a specific tissue. So that's important to know. So now I will focus on head and neck and on xerostomia mostly to kind of try to explain you how important these stem cells are and how important it is that they survive your radiation treatment. So this is a plan of a patient with head and neck cancer. And you can see here the dose to the tumor. Actually, it also gives a dose to the different salivary glands here, the parotid, submandibular gland, and sublingual glands. This has devastating consequences for the patient. As you know, used amount of saliva is giving the patient xerostomia. The teeth fall out, they get a dry mouth, and they cannot speak anymore. They don't sleep, and they have thirst, and they cannot eat properly. And even with the best radiotherapy currently, still 40% of the patients develop this type of xerostomia. So also from tissues, we can now actually grow stem cells as organoids. And I'll show you an example here from my lab where we grow organoids of salivary glands. And you can see here that from a single cell, a single stem cell, you can actually grow within a couple of days an organ that already looks a little bit like a salivary gland. There's a grape-like structure. You can take these organoids apart again and regrow them again, and then grow them endlessly, showing that these stem cells actually can self-renew. And you can see here, if you use the proper medium, you can actually grow them for more than a year, and you get a lot of stem cells. But the nice thing is that you can use them to study radiation response. And to show you that these organoids actually resemble the tissue, you can see here if you make a cut through these organoids and you stain for aquaporin, which is a label for acinar cells that produces saliva in the salivary gland, and these are green here, are abundantly present in these organoids. You have even smooth muscle actin cells that are present around the organoid that normally would secrete out the saliva into the ducts, and these showing you that these organoids actually resemble the normal tissue. And this is important to understand because this is what we did. And even if you transplant these organoids, you can actually see that in an animal that you do not transplant, you get a reduction in saliva production after radiation. And if you treat them with these organoid-derived cells, you can actually restore the function of the salivary gland. And this is very interesting, and that is also now what we actually do in the clinic, and we treat patients with these stem cells to repair their salivary glands, and hopefully that works. And you can see here that these cells then after transplantation take over the duct here, and these are all the brown cells here, just to show you how potent these cells are. And these organoids actually contain stem cells and to study radiation response and to see if we can develop a stem cell therapy. But we noticed that the cells in the salivary gland of a person do not all have the same radiation sensitivity, because we get biopsies from different parts of the gland. we tested how many organoids we can form. Oh, we did not think that these would all be as sensitive, right? So I miss a part, sorry. So, and actually we know that the we can grow more stem cells from the central part. So what we did is we radiated a cell in the lab with protons, which are very specifically irradiating certain parts. And you see that if you radiate 50% of the cell, radiate the bottom part of the salivary gland, you get less than 50% effect, what you would expect. But if you radiate the upper part, you get more effect than what you expect on the volume that you radiated. So we radiated a different part of the gland and eventually came to the conclusion that this part in the center of the salivary gland is the most sensitive. And that is because it contains most stem cells. And you can see here how this looks like. So this is a total. The bottom part completely destroy the bottom, but the upper part, where the stem cells are, you actually kill that part. Kill the. You would also regenerate. Just by killing the stem cells in the upper part, you can kill the whole gland. And so this is the slide I was looking for. So if you take a biopsy from patients here, you can see that if you can grow organoids from these, as you can see here. But if you take them from these different sites, you can actually see that especially in the site E, which is the site here in the center of the salivary gland, you can grow organoids, although the stem cells are not located much around this area, as you can see here in the ABC. Peter van Luik, a postdoc in the lab, did. He compared treatment plannings of patients and correlated the dose of the dose to a pixel in the treatment plan to the chance that the patient gets sclerostomia. And you can see here, the more red it is, the bigger the chances that dose to this area is giving the patient sclerostomia. You can see there's a hotspot in this salivary gland of this patient, and this hotspot is actually here at the part where most of the major ducts are that transport their saliva, and the part which we found also to be radiosensitive in our animal experiments. So to make a long story short, we did a clinical trial on this, where we randomized patients with 2 radiation schedules. So this is the normal IMRT plan, where you try to spare the whole salivary gland. And this is what we call the stem cell sparing IMRT plan, where you only spare the part where you have your stem cells, and to reduce the dose there as much as possible, of course, without changing the dose to the tumor. And indeed, this area actually that you radiate is actually determining the response of the patient, as we recently published, and this is also already confirmed in another study. To go a little bit more into detail, this is the clinical trial that we did. Every patient gets 2 plans. They are randomized into one or the other plan, and then we followed them up now for. And what you can see is that you see a specific response for the parotid gland, because we try to spare the parotid gland only and not the submandibular and sublingual gland. So the parotid gland is responsible for daytime sclerostomia, because if you this produces most of the saliva during your day, and the submandibular and sublingual gland, they produce most of the saliva during the night. So what we now see, if we spare the stem cells in the parotid gland of this patient, that during radiotherapy you see both in daytime and nighttime sclerostomia an increase in sclerostomia level in these patients. However, when you spare the stem cells, you can see that this is actually reducing in time, looking at that salivary gland is regenerating, and whereas a standard IMRT, this is not the case, and it is kind of stable, but only for the daytime sclerostomia, because that's related to the parotid gland, and not in the submandibular gland, where you see that the sparing of the stem cells is actually not helping at all, because you did not spare any stem cells of the submandibular gland. So this shows you the importance of the stem cells in the radiation response. And this also, yes, I think I'm going well in time. This is also very important for the retreatment tolerance of normal tissue, because the retreatment tolerance is dependent on time, doses. And this was not the question, so I hope that I can explain a little bit in this very short time how this works. So, in general, if you want to re-irradiate a patient, it's often characterized by a very narrow therapeutic window. And the potential, it may be that you have a decreased efficacy, and that could be due to the fact that you have surviving stem cells if you have a regrow of your tumor, and these surviving stem cells are potentially more resistant to radiation, so your radiation might not work that well. And you can expect an increased toxicity, because especially in late responding tissue, the cells that are damaged have a memory, and if you inflict, if you give more dose and overdose, you affect more stem cells, and it may induce an excess response of this normal tissue. So you have to be careful to really know what the cumulative dose at the end is that you will give these patients, both on the tumor and the normal tissue. So, as you say, radiation and then a pause and radiation. So what are the key questions that you have, that you need to know before you start re-irradiation? First of all, you need to know whether or not there's any restoration of your normal tissue tolerance. And sometimes you see that is possible. Then, of course, you have to think by yourself, am I are you different because you just want to help the patient for some time? And then, of course, you have to choose what type of secondary treatment you want to use. Do you want to use external beam radiation? Do you want brachy or saber? Or maybe in Holland we have then protons. That is also could be because you can spare the normal tissue potentially. Then you have to calculate actually the tolerance of your normal tissue by using, for instance, the EQD2. So you know from your basic treatment that that you, for instance, if you treat a tumor with 72 gray, that you have a certain tolerance, and you can calculate that how much of that tolerance for the normal tissue you have used, for instance, and you have to go back to your treatment plan, which you originally have, and check how much of the total tolerance dose of the normal tissue you used actually in the first time you irradiated. And then you can see if there's some tolerance remaining, or that the restoration of the normal tissue may increase slightly the tolerance of the normal tissue that you are co-irradiating, right? So this is very important for the safety, that you look at the toxicity time scale and the toxicity severity of the patient that you may already see before you start retreatment. So, so several indications that you have to potentially in prior treated areas, right? So it could be a recurrence within or in close range of the gross tumor volume, or it may be a new primary tumor in the radiation field, right? And since cancer survivors have an increased risk of developing these, they grow older, but they retain the risk before because they have all these predisposition factors, right? So, and this is only re-irradiation, of course, if the secondary tumor is within or close to the initial high-dose treatment volume. And of course, you can also see, potentially see nodes and metastases that you want to use re-irradiation for. So before you decide to re-irradiate, you have to look at the initial radiotherapy. You have to see what the doses that you gave, the volume that you irradiated, and the spatial relationship to the required re-irradiation field and volumes. This seems logical. Also, you have to include whether or not the initial treatment was done with extras like chemotherapy and biologicals, which may also inflict your tumor. But most important is that you assess the time interval between things, because it's not trivial to do a re-irradiation in your patients. So So like I explained already, you can calculate your tolerance of your normal tissue and your tumor by using the EQD2 model. So you calculate how much of your normal tolerance you already have used in your previous irradiation, and using this formula, and then taking into account that you can calculate for instance, for early reactions, 10 gray and tumor response often, depending on your type of tumors, 10 gray and 3 gray for late reactions. So you know your tolerance dose, which you can have the EQD2 tolerance, which which you don't want to go above, right? So if you would, these are defined already that you have, right? Then you can calculate the percentage of the tolerance that the initial treatment has been given. And then, of course, you can go up to the tolerance dose of this tissue. But it may be that your tissue is, depending on the time between the fractions, is also regenerating a little bit already, indicating that you could give potentially a little bit more dose to the tissue. So, do you find restoration of tolerance, right? So, if the radiation tolerance within a given volume of the organ has already been exceeded during the first treatment, you cannot do a re-irradiation, because there won't be any restoration of the tumor, and that means that it's impossible to re-irradiate the patient. And this, if you see, for instance, that a function is already lost, or for instance, skin damage, you see already fibrosis or other things that make you aware of the fact that you already have exceeded your tolerance in this patient, then you should not re-irradiate. However, if the initial radiation treatment was at subtolerance dose range, then you can consider to re-irradiate to a subclinical when the induction is only subclinical and or you see minimal damage, but also after possibly a long-term recovery and potential residual damage at longer periods, you have to consider this, right? So in principle, if you're below subtolerance, you can expect that there's some regeneration of the tissue potentially, and that you can treat the patients. So when is a patient eligible for re-irradiation? With especially patients with a likely quality of lifetime to progression benefit of the anti-cancer effect of retreatment, right? So you have to consider that. Or patients that who are likely to have a bearable late toxicity, right? So this is what you need into consideration. So I don't have time to show all the different tissues and why we get to this response that I will show now, but some tissues can increase the tissue tolerance considerable after for retreatment, especially early responding tissues like skin and oral mucosa. You can see here that this is the initial dose that is given to your radiation field, and radiation dose in percentage of the equivalent tolerance dose you can see here. So normally this is the dotted line is kind of the benefit line, right? If you go below the dotted line, it's actually the opposite. You can, but if you go above the dotted line, you can see you do more retreatment. And the gray area, you can see that you can retreat these patients actually above a certain tolerance dose already for say 120%, if the initial dose is not too high, and if the time allows that, right? So this is for early effects, but for late effects it's a little bit less, right? But because regenerate so much. So this is for skin and oral mucosa. This is for lung pneumonitis, and here you see that's only the early effects that you can stop a bit. This is for spinal cord. So even the spinal cord, you can go up to a little bit higher level than the initial radiation tolerance if you wait long enough, right? So in principle, for the spinal cord, you at least have to wait a year until you have reached a certain tolerance that you can use. And please if you want to do that, check the radiobiology book where all the details are in that I cannot give at the moment. However, there are also some tissues that do not tolerate any retreatment at all. And these are the kidney and the bladder. So although we don't know exactly the mechanism, so the mechanism here is repopulation of your tissue with, for instance, cells that repopulate the blood vessels, but also the white matter in your spinal cord. But here, the effect actually, if you retreat, is that you go even below what your normal tolerance is of your radiation organ, right? So kidney and bladder, if these are involved in your radiation field, you should never re-irradiate again, because they're actually more sensitive than they were before, and you cannot even go up to the normal tolerance level. A certain tolerance. So you have a residual tissue tolerance if no long-term restitution is occurred. So that is often short after radiation therapy, but sometimes you have some long-term recovery where you can give a higher dose and add a little bit above the 100% tolerance that you already have. But some tumors actually are some normal tissues are progressive, and you cannot give them any extra dose because they will actually go below the tolerance dose that you have. So there you have to be really careful. So in general, radiation with clinical data, it shows you that you really have to be cautious, because all the data where we know real human data from, so the previous data are all from animal experiments, you have to be extremely, there's an extremely heterogeneous population in all the studies that have been published. So they combine curative and palliative treatments in the same series. There's a changing in staging of and changing in radiotherapy techniques, which makes it very difficult, and changing in scoring of the normal tissue damage. So actually, the knowledge we have so far on re-irradiation is mostly due to the fact to the stuff that we do in animals, and especially in spinal cord, which is very important. This has been studied in monkeys, which show you that. So, because I was asked to focus a little bit on head and neck irradiation. So the radiation risk that you run if you do irradiate head and neck area, the one thing is the carotid artery. In some studies where they compiled a lot of patients together, so in 1,550 patients receiving salvage head and neck irradiation, 41 patients actually had a blown carotid, which is in 76% fatal. So this is something that you need to take into account, right? That's a very late responding organ, so that is difficult in re-irradiation. Other, of course, major complications include fibrosis, mucosal ulceration, necrosis, and osteonecrosis, and with substantial variations in the incidence rates between studies. So that's also kind of difficult. However, despite these treatment-related morbidities, still high-dose re-irradiation is recommended with the constraints, of course, I proposed. So the review of retreated patient series indicates partial long-term recovery of the head and neck tissue, particular with intervals bigger than 2 years. So this is something you really have to keep in mind. The longer the interval, the potential to do re-irradiation is a little bit better in head and neck. Prognostic factor for the outcome of toxicity-related deaths, of course, because if it's the bigger volume, you also radiate more normal tissue. Well, you do have with radiation a higher risk of late damages, as you can see here in this curve. With a single course, you have this level of complication-free survival. But in re-irradiation, you can see that the curve is much steeper, and you have much more patients that have, after re-irradiation, toxicity, right? So that is occurring earlier and to a more bigger extent. But a cumulative total dose of 20% complication rates at 5 years is higher than predicted from single course treatment, right? So the EQD2 here is 86 to 67, which means that there is some partial recovery. So local control rates can be achieved because these tumors are often also more resistant to more than 30%. With a total retreatment dose of at least 50 to 60 gray, and lower doses actually are not interesting to do because they're ineffective. So that means that to 50 or 60 gray, to already a low tolerance of your normal tissue, it's better to do something different. But still, if you do this, there are severe complications observed up to 60% on long-term survivors. And this is generally associated with a higher cumulative total dose and a shorter interval before treatment, right? So this is exactly fitting the biology data that I showed you. So how can we proceed with that in the future? Data and better ways to do this. So we need to evaluate how comorbidities and quality of life considerations should be incorporated in the treatment selection and prognostic perspective of these patients. We should know detailed information of the deviations that are described from the first irradiation and of course from the second. There should be an inclusion of baseline quality of life, smoking history, age, and comorbidities, which actually influence the response of the patient. There should be a very individualized approach for specific tumors or patient characteristics. We should think of what the HPV status is and potentially the EGFR expression status. And at the end, before we had to optimize the retreatment, I think we need multi-institute research. And these are now luckily starting to appear because people realize that, and there are now other options for retreatment also that makes it more possible to help these patients. So in summary, clinical data support radiotherapy as a treatment option for recurrences or second tumors. However, if the tolerance already has been exceeded before you re-irradiate, it's impossible to do that without severe damage to the patient. And we have to take into account that the risk of normal tissue damage is really bigger, and the impact on quality of life therefore must be considered, considering also, of course, the chance of the patient to survive the treatment. So I know it was a lot to digest in this short term, but I wanted to give you an overview. So maybe you can re-look at the presentation again afterwards if I was a bit too fast, maybe. But still, I'm happy to answer some questions now if there are some appearing in the chat box or so. Thank you very much for listening.
Thank you so much, Professor Kops, for the excellent presentation. So if the attendee have questions, you can write in the chat box. Right now we have one questions in the chat box, but first Dr. Judi to give some comments about the clinical aspect of the radiobiology in related head and neck cancer. Dr. Judi, can you give some comments about the fractionations concept in the clinical aspect? Thank you.
Yeah.
Yes, thank you so much, Professor Koppers, for this great presentation. I hope you can hear me well. I will keep it short to allow other participants to ask questions. I think it was very interesting to hear about the research your group did on salivary gland organoids, which is very promising and already established for the head and neck cancer patients. And also regarding the re-irradiation, which is a great challenge for these patients regarding the chance that these patients develop a second tumor. I have one small question regarding the salivary glands. The RCT was on parotid glands and to protect the central duct, or the excretory duct. Do you believe it will be these ducts?
It could in principle be the same because the biology is not so different. Only the submandibular and sublingual gland are a little bit more compact and smaller also, but in principle you could do that. Only with the current radiation technologies it's impossible, because it's already very difficult to spare anything of the submandibular and sublingual gland. And then focusing on the area where the stem cells are, it's even more difficult. So also therefore we also don't really have data from the clinic to see if we can do that. And we showed it in the parotid gland because we have many patients with very deviating dose volume histograms, right? And then you can pinpoint it to a certain area which may be hypersensitive. But the submandibular gland or sublingual gland are either completely in the field or not at all, right? So that is very difficult to pinpoint where exactly then this area would be, although the biology is not so different. So if you make a cut through the gland, you can see the ducts and you can see the stem cell area. But then to find where this is specifically in patients, it's much more difficult. So therefore also we focus our stem cell therapy now on the submandibular and sublingual gland. And the first patient that we are treating with these organoid-derived cells are actually submandibular gland irradiated patients. So maybe that would be a solution for those patients, or not. But I know that's
yes. Oh, that's great to hear. Mm-hmm. All right. Oh, that's promising for the future for these patient group. All right. Thank you. I'm wondering if there are questions in the chat.
I see one in the chat.
Yeah, maybe. Thank you, Dr. Judi. Maybe Professor Kops can answer the question in the chat box first.
So let me read it. Thank you for the excellent. Regarding alpha beta ratio, to my understanding, the ratio of a dose, is correct. That's sensitive to fractionation spice. If yes, so why prostate cancer? So prostate cancer, it's about the alpha beta of prostate cancer, right? And it's a very good question, because the alpha beta of prostate is also low, like late responding tissues, right? So you could imagine there that if you would fractionate your dose, that the cancer would benefit as much late responding tissues, right? So that's very fair to think that prostates is not necessarily better treated with hypofractionation, but that in principle you could do hypofractionation there, because responding tissues which you have to calculate. So in principle, I think already in the clinic, so I'm more of a head and neck brain person, so I don't know so much about the lower part. But in principle, you could do hypofractionation for your prostate, but this has to be very carefully done, right? Because there's a wide diversity of and inconsistency of alpha beta measurements. So in principle, I think it would be safe to kind of try to hypofractionate radiotherapy a little bit. Another issue is that if you hypofractionate, that you would shorten your treatment time, but that actually is maybe not a very good idea, because in that case, although since prostate cancer is not very rapidly proliferating in general, you would also diminish the repopulation of your normal tissue and for the early effects, right? So in principle, gut damage, for instance, is repairing already during radiation time, and after that very quickly. But if you shorten the time where you give your complete doses, your normal tissue, in this case, for instance, the gut mucosa and the villi there, might not be able to keep up with the regeneration, and you might get more early to consider.
Okay, thank you, Professor Coops. I hope this answer can explain clearly about questions. So maybe I will continue with other panelists. Dr. Ericko, please. Do you have any comments or questions?
Yeah, thank you. It's a great presentation, Prof. Coops. And I would just want to ask if the radiobiologic response is depending on ethnics or genetics. Is there any difference between Asian or Europeans?
Yeah.
Is it possible? And also, I would like to ask, sometimes we found in a clinical settings that a patient who has already had a chemotherapy and the response is not that good in chemotherapy. And if we're doing a radiotherapy, usually the response is not that good either. So is there any effect from chemo that happens in a radiobiologic things with a side effect and radio resistance? Maybe that's all.
Yeah. First, especially for head and neck cancer, I think that Asian people maybe respond a bit different than European, but it's very difficult to actually pinpoint that to specific genes, right? But it may also be related to yeah, maybe other health issues like the smoking, but also the different chewing of this I don't know the name anymore of this how you call it, this nut that increases the chance of getting tumors, which are potentially a bit different, right? I know that you have more troubles actually with head and neck cancers than we have in Europe. I'm not aware of any data that show a difference in response after radiotherapy. I do know that HPV, for instance, would matter a little, would give you a different dose response, although many studies have been done to change the schedule of HPV, for instance, to de-escalate a little bit. But so far that all has not been so well, did not work so well, right? So although there might be genetic differences, I think it's too difficult to see exactly how much it is to change, to give her a different type of radiation treatment, I think, for now. So maybe in the future we can do more specific analysis, maybe using organoids also, to see if we can find differences. And yeah, although there probably is a genetic difference, I think it's difficult to translate that immediately to a radiotherapy change or so. I don't think so. That can be done. With chemotherapy, it's of course very dependent on the type of chemotherapy. So if you use a chemotherapy like cisplatin, which is also directly damaging the DNA, I can imagine that the response of the patient to that chemotherapy or radiation might be very similar, right? Because it will both affect how a specific patient responds to DNA damage. If you have chemotherapy that are inflicting cell death in a completely different way by metabolism or whatever, it might not be comparable to what you see with the effect might not be the same as what you see with radiotherapy. So the interesting thing is what we do now here in Groningen is that we grow tumor organoids, and we do that now from esophageal cancer. And we get biopsies from the endoscopy that the patient gets, and then we grow from those biopsies, we grow organoids, and we treat them with chemotherapy, two types of chemotherapy and radiation. And you actually see that these organoids reflect the response of the patient after if you treat them, so that you could use that as a predictor. The three components. So two chemotherapies and one radiation together, then it predicts for the patient. But if you use the chemotherapy separate, then they don't predict the response of the patients. So that means that, of course, that the individual treatment is not necessarily responding, we call it, predict the response of a patient on forehand, because they might affect different pathways, right? And that the combination actually is necessary to, at the end, get your optimal response. So I don't know if that helps that answer at all, but yeah, I think yeah, if you see something like this, I think it's good to consider what type of chemo you give, and maybe you should change the chemotherapy if it's like in the same pathway after radiotherapy. Yeah, I tried to change my video, but I see it's not working very well. I don't understand because I have no background thing. It's just my messy room that you see.
Okay, thank you. Is there any more comments from Ericko? Question?
No, thank you, Prof.
Okay. Okay.
If you still have a question and you don't dare to ask it, you can also send me an email, and I can try to.
Thank you, and I would like to thank to Prof. Group for the explanation from the basic to practical, which was very coherent and easy to understand. My name is Dion. I'm a radiation oncologist in Kariadi Hospital. First of all, I would like to share my experience about hypofractionation radiation in cases of bulky tumor in the head and neck. In several cases of head and neck cancer at our center that were inoperable or chemo resistance. And we underwent a peer group discussion or some tumor board meeting, and the conclusion mostly just undergo radiation treatment and no more option for the other treatment. And most cases are carcinoma. We perform fraction, hypofractionation, and hypofractionation followed by normal fraction in different patients. Just an experience, and all formulation was calculated with the same BD. In normal fraction, the change in tumor size wasn't very significant, and we calculate resist assisted by a radiologist. And in hypofractionation, let's say 40 and 50 gray in 8 till 10 fraction, most patients drop out due to severe radiation side effect. Hyperfractionation at the beginning of the treatment and the normal fraction and the subsequent treatment program until completion. So our reference about hyperfractionation and from several publications such as Sticky et al., UC and Peking University that state about hyperfractionation irradiation also trigger hemostatic immunosuppressive mechanism that may counterbalance anti-tumor effect. And it's better the result for we begin in hyperfractionation and we follow by normal fraction. So that's our experience. Next, maybe we will make our publication about this case, and maybe I will ask Prof. Coops for your opinion about fractionation of bulky tumor. Thank you.
Yeah. Sorry that my video is not working well because it's weird, but okay, I cannot help that. Yeah, so it's a very long question and a very interesting problem because people tend to hypofractionate more and more. As a biologist, from the biology point of view, you know that if you hypofractionate, that you will decrease your therapeutic window, right? That means that you will have a bigger chance of getting normal tissue toxicity. So the successful hypofractionation trials has to do mostly with volume. So if you hypofractionate, and you can do that, and it's been shown very clearly in lung, right? That if you use very high doses, single doses, or a couple of multiple doses, you can actually very nicely kill your tumor, but only because you radiate a very small part of your normal tissue. And that depends very much, of course, on a normal tissue that's in your radiation field, how far you can go. So for instance, in the lungs, you will get fibrosis of these high dose single beams, especially in the beam area, right? You get this type of fibrosis in your lung. But as long as that volume is limited, the patient might not ever notice it, right? Because you have a spare volume. Also, that depends a lot on, of course, the basic status of the patient. For instance, if it has already COPD or all these kind of background, right? Because then it's more difficult. So if you would translate that to the head and neck, by doing hypofractionation, you will get a lower tolerance of your normal tissue, which you can calculate with the BED. But if you keep the volume small, for instance, if you would be able to spare like the contralateral parotid gland, for instance, then that would be potentially okay for that gland, right? On the other hand, if you give very high doses to even a small, like the spinal cord, this may be very dangerous, right? Because then it's more a serial or organized organ where you, if you inflict even a small volume that is damaged, then you might already inflict the damage, right? So going for hypofractionation is mostly a volume issue, and you have to make sure that you, if the volume is less, then you can potentially see that you can do a hypofractionation very carefully. But if the volume is too big and you do a hypofractionation, you can count on it that you get more toxicity than you would get if you do a normal fractionation. Is that answering your question more or less?
Yes, thank you. But I think we more concerned about the light effect in OER, like spinal cord and parotid gland and the other OER in the head and neck compartment.
Yes, so there you have to take care. And I think the salivary gland, if you do a reduced volume, you might have spare volume that is okay. Spinal cord, if you reduce your volume and give a higher dose BED, then you might not save the spinal cord, right? Because then the volume doesn't matter so much because it's a serial organ.
Okay.
Yeah.
Thank you. Just we back in BED and QD2.
Yes.
Yes. Thank you, Prof.
Thank you, Dr. Dion, for the answer. Because we are run out of time, so the committee want to ask the picture for the attendee. Dr. Dika, can you take our picture?
Dear respected Prof and Doctor, my name is Dika from IRORA, Indonesian Radiation Oncology Research Association. First, I would like to thank you for joining our webinar today. Now I will assist you in taking our group photos. The picture will be taken twice, so kindly turn on your camera and please hold still for a brief second so we can click a clearer picture. Okay, 1, 2, 3. Okay, once more. 1, 2, 3. Cheese. Okay, back to you, Dr. Hendro.
Thank you, Dr. Dika. So I would like to thank you for Professor Coops for the presentations, for the lecture, and also Dr. Judi for spare the time joining these webinars. I also want to thank you for Ericko and Dion to become the panelists for these webinars. So before I close this webinar, so the conclusions for these topics is about the basic concept of radiobiology. And then there is we also can develop stem cell therapy for the xerostomia. And also Professor Coops already gave us about the principle of re-irradiation in head and neck cancer. So we must balance between the efficacy and the toxicity. So the key point that I can get from the radiation is if we cannot give 6 degree, maybe we have to consider other modalities. And then hyperfractionations in the radiation is more beneficial than hypofractionations. Hypofractionation only we only can deliver in the low volume tumor. Any more comments, Professor Coops?
No, that's very well summarized. Yeah.
Okay. Because we are out of time, so I want to close these webinars. Thank you so much for Professor Coops, Dr. Judi, Dr. Ericko, and Dr. Dion, and of course to all attendees for this evening webinars. Thank you so much. I hope we can see each other in another occasion. Thank you.
Okay. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you, Judi.
Thank you, Rico. See you next time.
See you.
See you
We'll
next time.
continue
Bye-bye.
WhatsApp.
Yes, absolutely.
Thank you for arranging, Ericko.
Thank you, Dr. Judi. Thank you, Ericko, for connecting IROS with the Netherlands group.
Yes, thank you all and see you next time. Bye-bye.
Bye.
Bye-bye.